this is a unique event in many ways, and Dr. Huang's presence actually is courtesy of two people who I want to thank right off the bat. The Council of Foreign Relations, of which Dr. Huang is a member, generously offered to support his visit here. And he came because he was teaching in Diana Newton's class on East Asia. So we owe both of them big thanks, particularly Diana for putting this together. Thank you very much, Diana. It also is a great opportunity because, as far as I know, this is the first event at the Job Center and the Center for Health and Social Policy in post-launch. We may have done a couple things in the past, but hopefully this will be the first of many such events. And this is on a very important topic, obviously, global public health and the issue of pandemics and what the global response will be and what the U.S. response will be. And Dr. Huang is really uniquely qualified to talk about these. He's written extensively on global health governance, health diplomacy, health security, and public health. He has a number of very important publications and is working on a book on many of these issues right now. He, as I mentioned, he is a fellow with the Council of Foreign Relations. He is also an associate professor and director for global public health studies at the John C. Whitehead School of Diplomacy and International Relations at Seton. He's got a long list of accomplishments, and we are grateful for him making the trip back east. Best I could promise him was terrific conversation questions, some reasonably warm weather. So we've delivered on one out of the two, and hopefully the discussion will be good. Without further ado, please join me in welcoming
Thank you. Can you hear me? Okay. Well, thank you, Frank, for that very generous introduction. I certainly feel warmly welcomed here, and fleeing from maybe a couple of days from the cold and competitive New York is not a bad idea. So I thank Diana for inviting me over, and thank you for the Stroh Center, Frank, for providing this venue, and thanks for the Center for Health Policy for sponsoring this event, co-sponsoring this event. Today I'm going to talk about a topic that is probably faded in our memory, the pandemic response in East Asia and implications for U.S. global leadership. When I say East Asia, I mean the Northeast Asia, Great China, Korea, Japan, and Southeast Asia combined. We know that the 2009 flu pandemic, which is popularly known as swine flu, caused by a new strain of H1N1 influenza virus. I said H1N1, not H-I-N-I, because one of my colleagues whose grandma, told him that Heine virus is really scary. What is Heine virus? The outbreak was first observed in Mexico in April 2009, not far away from here. After early outbreaks in North America, the new virus spread rapidly to all parts of the world. By May 8, 2009, the criteria for moving to the highest alert level had already been met, although the World Health Organization, the WHO, did not announce a full-blown pandemic until June 11th. In November 2009, the pandemic began to pass its peak in North America, although a worldwide steep decline of the number of cases did not occur until May 2010. August 10th, the WHO declared the official end of the pandemic. By that time, most countries had confirmed infections from the virus. That led to more than 18,000 lab-confirmed deaths worldwide. So In this presentation, I'm going to first give an overview of East Asia's policy response. That will be followed by an evaluation of its containment-centered strategy in responding to the pandemic. And then I'm going to provide an explanation, analysis of the rationale behind East Asia's heavy-handed approach by handling the pandemic. And I'll conclude with discussions on some policy implications for global health governance and U.S. Global leadership. We know that the global spread of H1N1 influenza virus has prompted countries around the world to intensify their efforts to control its spread and protect people's health. In handling the disease outbreak, the differing policy response between countries and regions has been how to manage the initial cases and transmissions of the virus. There are two approaches here, right? Containment and mitigation. Okay? The containment approach, containment has nothing to do with the strategy U.S. adopted during the Cold War. Okay? So the containment approach emphasizes essentially active case finding, confirmation, extensive contact tracing, treatment of all infections in order to contain the new virus within a limited area or to delay the spread to buy time for other interventions such as vaccines. By contrast, mitigation aims to slow down the spread of the virus in the community and minimize the societal and economic impact of the virus. Different from the containment-based strategy, the mitigation approach, they only treat those who are severely ill or those are in the high-risk groups, right, such as pregnant women, right, people with chronic conditions, asthma, for example. Okay? The rapid spread of the virus essentially called into question the containment strategy. Right? So on April 27, 2009, when the WHO announced the pandemic phase 4, right, it indicated that the epidemic had already started to spread to a level that no longer justified containment. Okay? Actually, in this country, right, the approach from the start was mitigation. Okay? In Europe, after initial attempts of containment, most countries quickly switched to a mitigation-centered approach, focusing on treating severe cases and preparing for mass vaccination. But compared with countries in Europe and North America, and also against the WHO recommendations, many Asian countries pursued a containment approach in responding to the spread of the virus. Okay? That is especially the case in Southeast Asia and Northeast Asia. Okay? So by the end of April 2009, we found that governments across the region had stepped up checks at air and sea ports in a bid to ward off the new virus threat. Almost all countries in this region instituted thermal scanners to detect the people with fevers. Okay? Countries such as China, Japan, Taiwan, they even began to conduct onboard inspections, right, on travelers coming from North America. Countries such as China, South Korea, Philippines, Thailand, Indonesia also instituted a ban on pork products from North America. Right? The United States, that includes essentially 3 states. One of them is Texas. In addition, countries in the region implemented strict quarantine inspection measures to halt the spread of the virus. On May 2nd, 2009, right after East Asia's first known case was identified in Hong Kong, the territorial government ordered a full quarantine on all the 300 guests and staff of the hotel where the patient had stayed. And similar, although less drastic, quarantine measures were implemented by countries such as Taiwan, South Korea, and Vietnam. And among those countries, China's response turned out to be the most aggressive. On May 1st, after a Mexican passenger who transited through Shanghai was confirmed to have H1N1 in Hong Kong, the Chinese government immediately suspended the direct flights from Mexico to Shanghai. It also embarked on a nationwide manhunt, asking local authorities to track down and quarantine all passengers who were on the flight. And as containing the spread of H1N1 became a national top priority, a torrent of state action was unleashed. The government began to identify and treat every H1N1 patient. Official media was filled with reports of government leaders chatting through video, of course, with H1N1 patients, and patients discharged from hospitals with flowers and smiles. Well, this is a very rare moment in Chinese history, where the government actually glorified a patient with flowers and certificates and smiles. Overseas Chinese students who choose not to visit their motherland during the summer break time was praised for their senses of so-called civic responsibility and patriotism. In addition to this blatant propaganda, China on May 22nd began tests on every inbound international flight. You probably have seen this, right? Masked health inspectors, draped from head to toe in biohazard suits, right? Boarded on the plane and checked each passenger for fever with thermal forehead scanner. And actually, until the end of May, if a passenger on board was found to have a temperature about higher than 37.5 Celsius degrees, the entire flight would be quarantined, and passengers would move to reserved places for further medical observation. Okay. One day after his arrival in Shanghai, in early June, the New Orleans mayor, Ray Nagin, actually was held in quarantine in Shanghai simply because a passenger in the row ahead of him exhibited flu-like symptoms. So it's bad luck for him, and also another bad luck for New Orleans. Well, in a move that is reminiscent of the use of the Foucaultian disciplinary power, by early July, China had thrown tens of thousands of people into government quarantine facilities. The efforts to track down a person for quarantine actually smacked of an Orwellian, some people say totalitarian approach to public health. Just to give you an example, right, the local CDC in Guangzhou managed to locate a taxi that had been taken by a suspected case using the GPS system, accessing the person's public transportation record, and mobilizing local authority residents to come forward with information that eventually led to his capture. Okay? So the fear and pressure was so high that the father of China's second H1N1 case even made a public apology on the local television for his son's illness. Okay. So such a containment-centered strategy was not formally replaced by a more measured mitigation-based approach until September 2009. So it is fair to say that among all the affected countries, China's non-medical response was the most extreme. So how effective are these response measures? On the surface, Asia's virus containment efforts were quite a success. By July 6, 2009, less than less than 10,000 cases, or only 10% of the world total, were in Southeast Asia and Northeast Asia, even though that region, they claimed nearly 1/3 of the world's population. Also, an aggressive approach decreased the effective reproduction number of the virus, so at least delayed the inevitable acceleration of the pandemic to the autumn 2009. The epidemiological data here about China supports the role of government intervention in slowing down the transmission, because you can see from this figure, significant increase of the cases of confirmed H1N1 did not occur until September 2009, the time China abandoned the containment strategy. According to a senior health official in China, this has bought the government more time to prepare for the next viral wave. And actually, in early September, China became the first country to mass produce the H1N1 vaccine 1 month ahead of the United States. Okay. We provide them the viral samples, but they were 1 month ahead of us. That being said, the containment measures did little to achieve the primary objective of the containment strategy, that was to prevent the spread of the virus in the local community. The sustained community transmission was observed in Japan in middle May, and China fared better, but was 1 month later, it also saw the community-level outbreaks in Guangdong province. Similarly, Singapore saw a community spread of H1N1 virus on June 23rd. The Singapore case is illuminating because with a small geographic area, a highly trained, effective, efficient healthcare service, the country was in a better position than its neighbors, to trace contact and enforce quarantine measures. So the bottom line is that it is impossible, simply, for a non-isolated country to stem the spread of such a highly contagious disease. Second, because asymptomatic influenza virus carriers can still shed virus, border screening measures are not an effective way of identifying cases or preventing transmission, even though they can be an effective monitoring technique. We have empirical evidence to support that. I did the study using the official epidemiological data and found that of the nearly 36 million visitors checked in China, only 0.036% were found to have signs of flu, and only 455 people, or about 1 per 100,000 visitors, were confirmed to have H1N1 flu. Similar studies were carried out in Japan and Taiwan that support the same conclusion. And also, there is no indication that rounding up apparently healthy individuals and confining them to government-designated hotels worked as an effective method of disease control. In fact, in China, by June 18th, only 23 confirmed cases were identified through this involuntary quarantine measures. Even home quarantine measures didn't work that well. In Malaysia, for example, among the more than 1,000 people placed under home quarantine, none of them have developed the flu symptoms. So while the aggressive government response was not that effective, the cost of sustaining the containment strategy was very high. Right? By cost, I mean direct financial cost. Right? China actually spent twice more than it spent on combating SARS in 2003. It spent tens of millions of yuan alone on enforcing the quarantine measures that include providing free lodging, free meals, free internet access, flowers, fruit baskets to people who were quarantined. That is quite a high financial burden. There are also, of course, a social economic cost. Those panic, self-serving protectionism hurt China's domestic pork industry and discouraged tourism and international trade. There are also human rights concerns and affected the country's foreign relations. The quarantining of 70 Mexican passengers, for example, triggered a diplomatic row with Mexico. There's also the opportunity cost, sustainability problem here. Right? The question is whether there were staff available, right, who could deliver the necessary response 7 days a week, right? And what else could not be done, right, because the human and material resources were fully engaged on case finding, contact tracing, and treatment. Right? In China, well, both Japan and China face the staff shortage problems. In China, because of the shortage of personnel, the government actually transferred the military personnel to do the temperature checking. Right? This is the picture that show the photo that show actually a soldier who had already worked for more than 10 days around the clock. Well, not around the clock. Had been worked overtime for more than 10 days. So he fell asleep while sitting up. There's also the problem in terms of opportunity cost, focusing on fighting the H1N1 virus, divert the limited health resources that could be spent on somewhere else, such as handling the hand and foot and mouth diseases in China, dengue fever in Malaysia, which both had a high mortality rate at the same time than H1N1. But all this boils down to a critical question. Right? Is it really worthwhile, right, to commit the resources to fighting essentially very wimpy virus? Right? Well, the H1N1 virus has proven to be a relatively benign one, we know. Right? Its virulence measured by the CFR, right, not Council on Foreign Relations, case fatality rate, it is only 0.048, right, which is even lower than that of the seasonal influenza. Right? Of course, even much lower than the dreadful Spanish flu and the SARS virus. Okay? Its transmissibility measured by the reproductive number, rho, right, 1.4, slightly higher than the seasonal influenza, but definitely not a terrifying level of contagion compared to the 2003 SARS, which has a reproductive number of 2 to 4. That means a person who is infected could infect an average of 2 to 4 secondary cases. Okay. Why I don't think that an ostrich policy would work here, but after seeing this, doing this comparison, I cannot help but pondering the counterfactual question, right? Would our lives be made a whole lot better if we were not aware of the existence of such a pandemic? Well, now that we've provided assessment of the implementation of the containment strategy in Asia, we can move on to the next question. That is, why did countries in this region pursue such a costly but ineffective strategy in handling a very mild pandemic? Panic certainly plays its role. Right? You know, that's society's natural response to an unknown and potentially disastrous disease. But what was seen during the 2009 pandemic was not just a media pandemic, social panic, but official panic, right? Inconsistent information, rapid policy changes that seem inspired by political demands, not medical need. To quote, we must be alert and prepare for the worst. Panic also cannot explain why, compared with countries in Eastern Europe and Latin America, many Eastern Asian countries implemented a more aggressive, more drastic, if not more draconian approach to the H1N1 pandemic. Right? That was evidenced by the more frequent and prolonged use of quarantine measures. The stringent reaction to the flu pandemic reflected the painful lessons East Asian countries drew from the SARS epidemic in 2003 and the bird flu outbreak in the same year. We know that decision makers, when they're overwhelmed by the uncertainty and complexities of the problems they confront, they tend to lean heavily on pre-existing policy frameworks, adjusting only at the margins to accommodate distinctive features of the situation. Prior to the H1N1 outbreak, Southeast Asian countries built their pandemic preparedness plans around that idea that a virus was going to arise in their backyard. So most of the plans focus on how to call the chickens. Okay? Many countries in the region failed to build and sustain core medical care, medical surge capacities. By June 2009, for example, most Asian countries had only 1% of their population covered by government antiviral stockpiles, compared to 25% in the United States and 50% in the United Kingdom. Few countries in the region had vaccine manufacturing capabilities. The inadequacy of medical surge capacity building led many countries in the region that were caught off guard by the new virus from overseas to heavily rely on pre-existing non-medical response measures such as travel and trade restrictions. And of course in China, because forceful measures such as travel quarantines, enforced quarantines were widely credited with helping stop the spread of SARS, actually quickly became the silver bullet for all infectious diseases. And of course, there's no such a thing, silver bullet, in combating infectious disease. Right? But even if these excessive government responses were not scientifically justified, it made perfect political sense. During the financial crisis, politicians, they would be credited for launching a high-profile battle against the virus, rather than getting the blame for failure in managing the economy. And in the Philippines, political pressures from hog farmers led to the government to impose the ban on pork products from North America. And Chinese leaders, they had strong political incentives to pursue an excessive approach, are not informed by science and epidemiology. Because on the eve of the 20th anniversary of the Tiananmen democracy movement, and in months leading up to the celebration of the 60th anniversary of the People's Republic, forceful government measures against H1N1 actually helped show up the government legitimacy. I knew in September there are already H1N1 deaths in China, even though the government official epidemiology data keeps on saying 0 deaths. When reporters came to me asking about that, I said there are problems, but they are not telling the reporters, who told me that there's where to find the death case, because I don't want to be seen as a party spoiler, because then I would be in big trouble. So what can we learn from Asia's response to H1N1? As the first officially designated pandemic in the 21st century, the 2009 H1N1 influenza presented a litmus test of the humankind's ability to handle major disease outbreaks in the era of globalization. Paradoxically, while pandemics are now firmly part of the globalized era, state responses to the spread of H1N1 are not. In contrast to the responses of countries in Europe and the United States and North America, many East Asian countries adopted a containment-centered approach in combating the H1N1 virus. It's like deja vu all over again. When the bubonic plague was engulfing Europe in the 14th and 15th century, rulers Milan and Mantua did not hesitate to implement draconian disease prevention and control measures, including inspection of travelers, quarantine ships, and institution of the Lazaretto to treat contagious patients. But as this study demonstrated, in the era of globalization, the containment measures were very costly to implement and sustain, and have only limited success or benefits in stopping the spread of the virus. But even so, many countries today still look to the centuries-old approach to contain the spread. So as far as this is concerned, East Asia's pandemic response is a classic example of the lack of the grasp of disease that is seen as symptomatic of globalization. But East Asian countries are not the only ones that utterly failed the test of globalization. In recognition of the global nature of the spread of infectious disease, the United States national security strategy under both Bush and Obama administrations clearly emphasized the importance of international cooperation in addressing the disease outbreaks. They were aware that lack of response capacities in under-resourced countries, which are at special risk during influenza pandemics. These countries pose a threat to U.S. human health security. They also present an opportunity for the United States to burnish its international image, right, through strengthening core response capacities in those countries. In fact, in September 2009, a U.S.-led group of 12 industrialized countries pledged to make 10% of their stocks of H1N1 vaccine available to the WHO for distribution to about 100 developing countries. The U.S. Department of Health and Human Service Secretary, Catherine Sebelius, they indicated that the donation could be triggered after 40 million doses were procured by the United States. But interestingly, as health transformed from a humanitarian, technical, low politics issue to one that features highly on top leaders' agenda, states' response to public health seems to be increasingly subordinate to political deliberations and interventions. Showing in the East Asian case, the growing politicization of public health problems can lead a country like China to pursue a political agenda that does not address the needs or concerns of others, as evidenced in the China-Mexico diplomatic role over the quarantine measures. That eventually undercut trust and goodwill among the states. The United States is no exception. If we give a closer look at the U.S. responses toward the pandemic, we found that while the United States today recognized that solution to global health problems necessitate neoliberal strategies of cooperation over disease prevention and control, its actions are still dependent upon the logic of politics. Okay? That is not based on science, not subject to the public deliberation, right, on the Machiavellian instinct of those in power. In view of the delay in the vaccine production and the strong domestic political pressures, the U.S. Modified its plan on donating vaccines to the WHO. In fact, 1 month later, in late October, the HHS Secretary, Sebelius, suggested that the United States would not donate the vaccine to poor countries until 150 million at-risk Americans had been inoculated against the virus. So as a result, the first WHO shipment of vaccine did not arrive in the developing countries until early January 2010, when the pandemic already passed its peak, right? And they were actually donated by drug manufacturers such as GlaxoSmithKline and not Western governments. By April 2010, when the pandemic almost ran its course, less than 229 million ordered doses of vaccine had been administered in this country. That means an estimated 71.5 million doses must be discarded if they were not used before they expire. By contrast, only 26 of 94 poor countries in need received the vaccines. So the existence, what we saw here is kind of vaccine apartheid, right? The existence of this vaccine apartheid sent a chilling message to the developing world. given the relationship between the lack of call response capacities and the heavy reliance on aggressive non-medical response measures in East Asia, the argument can be made that the lack of U.S. support in the developing world indirectly contributed to the excessive state non-medical responses to the H1N1 outbreak. And the continuous failure of the United States and other industrialized nations to adequately address concerns of such countries during the H1N1 outbreak would only encourage the widespread non-compliance of international health regulations that were revised in 2005, and also undermine the past efforts to protect public health globally. In fact, prior to the H1N1 outbreak, the Indonesian health minister already refused to share H5N1, the avian flu samples, to the WHO, arguing that big pharmas, industrialized countries, develop vaccines using the virus samples sent by the country free of charge, but they market the vaccine with prices too high for those countries to distribute. Okay. So the vaccine Apartheid only boasted Indonesians' so-called viral sovereignty thesis. Basically, they believe that the virus also, even though it can be moved from country to country, it doesn't respect the disease, doesn't respect territorial borders, but Indonesia claims it has sovereignty of this viral samples. Right? That is going to discourage further the sharing of samples of avian influenza, even threatening the vaccine production and public health preparedness. I said that is important because given the most recent cases identified in Hong Kong, Taiwan, probably mainland China, we're probably going to face a rough winter that H5N1, the avian influenza, is going to mutate and likely achieve efficient human-to-human transmission. Okay? So that is going to be another, possibly it could develop into another pandemic. But our reactions, our responses to the pandemic only discourage the sharing of the samples of avian influenza, which is so crucial for the development of vaccines, so crucial for for the international efforts to contain the spread of the virus. So not surprisingly, when the H1N1 pandemic hit Indonesia, the Indonesian Minister of Health threatened that she was going to punish anybody in that country, any scientist who cooperate with the United States Naval Medical Research Unit that was in Jakarta. Okay. So a state-centric, politics-driven response to the pandemics not only compromises the U.S. global leadership, but also by making obligatory information sharing and international cooperation more difficult to justify, actually increase the risk posed to the U.S. health security. So policymakers in the U.S., other countries as well, need to update their thinking about the threats of diseases as well as the strategies aimed at their resolution. I'll stop here and be happy to answer any questions you have.
Please. Thanks for the fascinating presentation. I was struck by slide about lethality and communicability and the difference in the various strains, and that SARS one is really scary. How is one of the problems seems to be the ability to communicate or differentiate different pandemics in terms of these two key variables, lethality and communicability.
To
the general public, I was just wondering, do you have is there a policy recommendation that you would have to better allow both health officials and also the general public to distinguish, or would that be a problem? So to make people clear that H1N1 is an issue, but it's not SARS, without creating kind of, how is that done now? The WHO, and how could that be done better?
Well, it is done by scholars actually. Though I haven't seen any systematic comparison between the viruses, the epidemics in terms of case fatality rate and the transmissibility. Especially in the initial stage of the 2009 H1N1 outbreak, I noticed the government draconian measures from East Asia, and I criticized that approach. I said, well, you said, well, if we allow that virus to spread, it's going to be another SARS. It's going to be fatal for China. But you fail to differentiate the two viruses in terms of transmissibility and case fatality rate.
Do people like you know early on, I guess that would be the question, would medical experts have known early on that H1N1 wasn't like SARS, or is this only after the fact? And I get it. If seeing something like this, would it be useful, or how would one convey, okay, SARS is the level of threat of this here, H1N1 is nowhere near that, or anything like that? At what point was the general difference in scale recognized by experts, and how could you get that information?
Yeah, when that virus was first identified, observed in Mexico, there was it seems that the fertility rate was very high, but later, actually soon it was found actually many of those cases that should not be counted actually were counted as H1N1 fatalities. So actually by early May, the U.S., European governments, many countries actually had gained more knowledge about the disease. They knew it was not as fatal as they thought, and even in China, to my knowledge, the scientists actually shared the information with the top government leaders, I think as early as May 8th. Okay? But still, we haven't seen that the government leaders in the region, China, East Asia, responded to that epidemiological data, and reacted based on this data. That I found very interesting. In fact, even after the mildness of the virus became widely known, some of the countries, including China, still implementing this draconian virus control measures. Josh?
Maybe I could follow up on that. How much of this, I mean, there is a national level difference in the way China versus some of the other countries like the U.S. dealt with this in terms of the containment versus mitigation, but it does seem like you could credit sort of the U.S. Non-delivery of vaccines and maybe the draconian policies in China to sort of fog of disease, fog of pandemic. Like, not enough was known, so even if the epidemiology is suggesting that the fatality rate is kind of low, it's new, so maybe they're going to get things wrong in the first year, but now if this emerged this year, maybe we'd be less forgiving if they embarked on the same set of strategies now that we know more about it. I mean, maybe you can talk a little bit about how much of it is just about the uncertainty of a novel disease.
Yeah, the uncertainty certainly played actually an important role here that affected the country's response. As you correctly pointed out, even after the mildness became known to the decision makers, there's still not much to learn about the disease. Actually, the WHO also suggested that this is a new novel virus. It could mutate into a more viral, more potential, also contagious disease. I think I'm not in a position to criticize the WHO approach, but I think in this case it seems that it exaggerated the virulence as well as the contagiousness of the disease. In fact, we know that until June, the WHO still refused to declare the end of the pandemic. So we need, the virus is still there. We need convene the expert committee to decide whether to end that, whether we should announce the end of the pandemic. So it's not until August to say officially this is the end of the pandemic, even though by April 2010 it's pretty clear, right, that it's going to that the virus is going to reduce into just a seasonal flu virus.
Could you comment on the importance of the quality of epidemiological reporting from different countries in terms of understanding pandemics? Because if the magnitude of the problem is being underreported, then obviously the success of policies would also not be accurate if you are not identifying so many cases. And that's because there are a lot of developing countries where the public health infrastructure is so poor that you would only find out someone having a serious illness when they are almost near death, especially for the severe conditions.
Yeah, surveillance capacity, including data collection of the diagnosis capacity, is actually a big problem in lower income countries. So that actually constrains their ability to collect reliable, accurate data. Okay, India probably, I would have doubt on the India data, but China, initially, its data, I believe it was more accurate than the number of cases, the data presented after October, actually after September. Because initially the government asked the local governments, the national government as the local governments, not to misreport, not to underreport. They would punish severely for those who underreported or misreported. But then, political factors intervened. The government actually had incentives to cover up, to create an image where there not that many. Actually, there was no death in the country despite the slightly increasing cases. A government official told me that in the eastern province of China, before the October 1st celebration of the founding of the People's Republic, the provincial governor convened a meeting, said we should make sure there was no fertility in our province. Because when he said we make sure no fertility, nobody dared reporting any fertility, right? So the data became much less reliable over time. So politics is another factor that's settled in. But speaking of capacity, even in the United States, we face the similar problems of obtaining reliable, accurate data for decision making. That is why we rely on statistical models, because many people who are sick, who had flu symptoms, choose not to go to the doctors stay at home, right? It's very difficult. And even those who admitted, that they were probably not diagnosed, and counted individually. So that is why we rely on statistical modeling to determine the cases and fatalities. And WHO knew that, aware of that. So that is why after July 6, 2009, it no longer required countries to report individually confirmed cases, although some countries, such as China, continue to report individual cases until the spring 2010.
Even in the U.S., didn't they have to send the samples to CDC for final confirmation for H1N1?
Well, if you you were tested, it would send to the CDC, but many of the cases were simply not tested.
So which country would you say was most successful in containing the disease?
Poland. Poland, I found this case very interesting. While these East European neighbors, such as Ukraine, actually were creating this panic, surrounding the H1N1, these leaders basically said, we are not going to take any draconian measures. They did not even encourage people to be vaccinated. So and they were fine. Right? They and that's. I think I probably need more data, countrywide data, to make a conclusion. But it seems that Poland did a pretty good job. In terms cost-effective wise, right? That in handling the outbreak, there's no panic. Right? The government did not need to commit tremendous resources to fighting this mild disease. Right? The cases fatality level is low.
How accurate are your models for predicting mutations? It seems to me politically that one of the problems would be to have all your army over here ready to go, and the virus with a mind of its own appears in a different form here. That seems to be our problem when we're just looking at flu vaccines, and you get vaccinated for something that turns out not to be this year,
right.
years, and all of those things.
Well, I think my model doesn't provide any clue for predicting the next wave of the virus. I think that's a job of public health experts. But as you correctly pointed out, even them sometimes they made the wrong predictions, and so making the seasonal the vaccines against the seasonal influenza actually much less effective than it was claimed. This year, I think. This seems to have done a pretty good job, with the H1N1 strain included in the vaccine, and at least so far I haven't caught any the viruses.
You alluded to the fact that we were, although our response was much different, we were just as unprepared in terms of our preparedness and response plans as China. We had also based everything on H5N1, even though we knew we could very likely be facing something that was originating here in the Western Hemisphere and something of a much lower case fatality rate. Our plans just aren't scalable, and they don't include very accessible or feasible methodologies for prioritization, which seems to really be at the root of the problem that you brought up with the U.S. missing an opportunity to stave off vaccine apartheid. So it seems like you'd asked the question whether it's worth really responding to wimpy viruses or even knowing about them. And I was wondering what your take is on the utility of of using these responses as a dress rehearsal for testing the methodologies for our decision making, especially as regards prioritization and allocation of resources, or whether you think because of the very different approaches to a containment focus versus a mitigation focused strategy, that the methodologies would be themselves be so different that it's apples to oranges, that there's no utility taking the lessons learned from this one type of virus and to prepare for a more virulent strain. I'm struggling right now with this prioritization model. It seems like everything we have out there to try and base prioritization on some sort of scientific basis is so methodologically heavy and detailed that I'm afraid that in an event it wouldn't be accessible. I'm thinking of like the Berkeley method for vaccine allocation. I mean, there's so many variables, and I just don't see decision makers really using that in a timely manner during an event unless they have some experience with applying that.
Right. Yes. I actually agree with you that the H1N1 case is sort of like a rehearsal, for the countries to deal with the next disease outbreak. And in fact, the Singapore government officials they publicly said that even though I disagree with their approach, for a time I was worried that because I had a working paper with the university there, they said there needs to be approved first by the Ministry of Home Affairs. So I was like, gee, because I was critical of the East Asians approach, that probably was not published my paper. But actually in the United States, what I'm critical with its approach in distributing the vaccines. I'm not critical of the U.S. handling of the entire outbreak. Actually, I would say, compared to the U.S. handling of the previous outbreaks, so this time did much better, did a much impressive job, in terms of responding to the outbreaks. What I'm not happy with is this hypocrisy, insincere attitude, in distributing the vaccines, in helping the resource-deficient countries in fighting the disease. Because on the one hand, we were telling the developing countries, you guys need to be alert, improve your surveillance response capacities, share your virus samples information with us. But they have nothing in return, right? Basically, we have a mechanism of sharing the virus, but we don't have any mechanism in sharing the benefits of that cooperation, right? So that makes our approach less sincere, more hypocrite, right? And that is going to hurt our ability to fight the next disease outbreak. Now, this is my central argument here. I assume you're a public health expert.
I don't think there's any experts when it comes to this. I mean, yourself excluded.
No, I'm not.
I would differ with your characterization of this strain as mild, as it caused much higher numbers of death in children and had a 28% mortality in pregnant women. So I think that is some of the reasons for the concern in this country. Were you aware of those statistics?
I think I've seen some of the reports, certainly that the at-risk groups, pregnant women and children, that is why the administering the vaccines, the priority groups that covered this segment of the population.
And I don't know that you can fault the United States for making the vaccine enough for the population, sending it out there. The high-risk populations were vaccinated, but as it became evident that this was in healthy individuals a milder infection, people chose not to be vaccinated. At that point, the vaccine had already been distributed to providers, so it could not have been recalled and sent overseas.
Right.
So I think there is more than one perspective to look at this and to actually what happened. And as for laboratory diagnosis of the infection, the state health department was totally overwhelmed by the number of specimens, and they finally had to say, no more, quit sending them. And so the cases were not able to be laboratory confirmed. It was assumed that 99% of circulating virus was H1N1.
Yeah, well, just the, again, what I criticized is the way, well, initially we promised to donate 10% of the vaccines after that 40 million threshold has passed, right? But then we changed our mind and said, no, we're not going to send vaccines to these countries unless we have 150 million at-risk people who are in these at-risk groups, their needs are first met. I think that approach, it's obviously political-driven decision. I think it's not a wise decision.
Maybe I disagree.
Okay.